So it's especially wonderful delight to do this. Dr. Laramie Smith is an associate professor in the Division of Infectious Disease and Global Public Health at the University of California, San Diego School of Medicine. As a social psychologist, her community-engaged research applies social and behavioral theory from a public health perspective to examine individual and socio-structural contexts, such as stigma, substance use, social networks, implicated in improving health equity among people living with HIV and substance-involved communities. She's skilled in quantitative and qualitative formative research methods and in the development, implementation, and rigorous evaluation of HIV prevention and treatment interventions in clinical and community settings. Across this work, Dr. Smith maintains an intersectional focus on gender, ethnic, racial, sexual, and substance use identities, and the mechanisms through which related social determinants manifest to undermine engagement in HIV prevention and treatment services. And with that, I would say that this paper that came out in Implementation Science was very exciting to us all. Laramie incorporated implementation science work for the past several years in her work, and this is one of those kind of jewelry of her implementation science work. So I am very happy that she will present about that today. Thank you for accepting this. I know that you are very busy. I will hand it over to you, and we will look at the chat. So if you have questions, please use the chat. And there will be moments in the presentation when Laramie will invite you to share your thoughts. So wait for that moment, please.
Yes, absolutely. Thank you so much. Let's see if I can get this up and running relatively smoothly. All right. So then here, let's see. All right, here we go. So I just want to, start by thanking you so much for the opportunity to present this work as part of this year's DISC seminar series. This is my first publication in implementation science, and so I can no longer say that I'm not a card-carrying member, I guess. So it's very exciting and truly an honor. Just like the technical note, I can't see if anyone raises your hand or puts a question in the chat while I'm in presenter mode, so please feel free to just come off mute and ask any clarifying questions if helpful. But know that I anticipate we'll have at least 15 minutes or so for a robust discussion at the end of this talk. So I really tried to prioritize time to talk with folks about this research. I just want to start by thanking all of our HPTN 094 participants, local communities, study staff, and providers who really make this work possible. It is a huge study, and none of this would have been possible without many, many people. In addition to my co-authors listed here, I also want to thank Del Berwin and Phil Andrews, who reviewed the implementation evaluation study design and provided in-depth feedback on this manuscript. I deeply appreciate their attention to detail and collaboration. I also want to extend a big thank you to my implementation science mentors and champions, Drs. Nicole Stagnick and Borsica Rabin here at DISC. And to the study co-PIs, Steve Shoptaw, Nabila El-Basil, as well as Radonna Chandler from NIDA, who saw the importance of integrating implementation science evaluation component into the HPTN 094 protocol from the very beginning. And this is the first HPTN funded protocol to have a formal IS evaluation implemented into it. To help orient us today's talk, first I aim to just provide a brief background on the study context and an overview of our implementation science framework and methods, and then dig right into our results. We'll discuss our pre-implementation neighborhood selection, characteristics of those implementation neighborhoods, and factors affecting a neighborhood's viability to deliver this complex intervention. And we'll follow up with a brief discussion and then more time for open dialogue with us outside of the presentation. By way of background, there are approximately 3.7 million people who inject drugs in the US, who disproportionately account for approximately 7% of all new HIV diagnoses annually. Increased fentanyl, which is a highly potent opioid in the US drug supply, has accelerated HIV and overdose risk among people who inject drugs. And Overall, we saw over 100,000 fatal overdoses reported last year, though not all of those folks were people who injected. There are highly effective evidence-based interventions to prevent HIV transmission and mitigate overdose and HIV-related harms among people who inject drugs, including antiretroviral therapy, or ART, and pre-exposure prophylaxis, or PrEP, that can effectively stop onward transmission of HIV when taken consistently, and also medications for opioid use disorder, or MOUD, that include methadone and buprenorphine, which are really gold standard treatments for opioid use disorder. And they work to both reduce overdose and HIV-related harms. But the uptake of these interventions is strikingly low. And it's important to note that international guidelines do recommend that these evidence-based interventions be delivered through integrated care models, but there are a number of barriers to that. So despite the availability of these highly effective evidence-based interventions in the US, the domestic HIV burden among people who inject drugs is driven largely by interconnected syndemic factors that include limited access to healthcare and medication for opioid use disorder, poverty, polysubstance use, and unmet mental health needs. The impact of these syndemic factors are further amplified by the criminalization of drug use and stigma towards people who inject drugs within our systems of care. And this contributes to the disruption or disconnection of folks from healthcare services, including limited access to HIV-related medications, MOUD, and hinders treatment adherence and retention. So in response, HPTN 094 uses a complex intervention called INTEGRA to help address these barriers. INTEGRA delivers integrated care, both ART and PrEP, as well as MOUD, through mobile units in local neighborhoods with peer navigation support to improve treatment initiation and retention among people who inject drugs. Increasingly, we know that implementation science is being used to aid in the planning and successful delivery of complex evidence-based interventions and their adoptions among people who inject drugs in both the US and abroad. Prior MOUD and harm reduction research has examined implementation facilitators and barriers within the organizational healthcare and social service systems, examined workforce capacity, as well as financing and policy contexts. In the context of HIV and substance use, implementation science frameworks and methods have been leveraged in the US specifically to articulate organizational and patient perspectives of harm reduction interventions for people who inject drugs who also have HIV, and to help expand harm reduction interventions through pharmacy services to people who inject drugs. But to date, fewer studies have utilized implementation science methods and frameworks to understand how the outer context can influence HIV and MOUD service implementation. So regarding our study, HPTN 094 uses a hybrid type 1 effectiveness implementation study design. Our primary focus is to determine the effectiveness of INTEGRA in reaching eligible people who inject drugs in local communities, who are then randomized to either the integrated care arm delivered on a mobile unit with peer navigation support for 26 weeks, compared to a peer navigation only arm that supports linkages to local HIV and MOUD services in the community for 26 weeks. At week 26, facilitated access to these evidence-based interventions ends, and participants are followed through week 52. The reasons we have an active comparison arm is an important point to raise here, because there is no standard of care condition for people who inject drugs in the US, given the syndemic-related barriers to accessing care we previously reviewed. So a standard of care arm would be a comparison to essentially reinforcing no access to health services, which was deemed unethical by all research and community partners. Our secondary focus of this trial is to prospectively characterize INTEGRA's implementation facilitators and barriers across our 5 study sites, which include New York City, Philadelphia, DC, Houston, and Los Angeles. The RCT component aims to evaluate the effectiveness of INTEGRA on 2 primary clinical outcomes, where we hypothesize that there'll be greater retention on MOUD and increased retention on ART or PrEP at week 26 in the integrated care arm compared to the peer navigation only arm. Our multi-phase implementation evaluation uses an embedded mixed method study design to first inform where we were going to deliver INTEGRA during the pre-implementation phase, and then to guide and optimize the real-time delivery of INTEGRA during the implementation phase. Also, we aim to use these data to understand how the local implementation context might affect INTEGRA outcomes and inform how INTEGRA could be implemented in similar public health settings during the evaluation phase. By the Practical, Robust Implementation and Sustainability Model, or PRISM, which is a multi-level framework that aims to move research finding towards healthcare practice. For HPTN 094, I articulated PRISM's 4 theoretical domains to characterize first the patient and providers' perceptions of INTEGRA's integrated evidence-based interventions, in this case buprenorphine for the treatment of opioid use disorder, as well as ART and PrEP. We then aim to capture different characteristics of both people who inject drugs and mobile unit staff that could affect the delivery of integrated care, as well as factors in the external community environment that could influence how integrated care was delivered by the mobile unit and accessed by people who inject drugs. And finally, system level factors and infrastructure needs that affected or were affected by the delivery of integrated care in the mobile unit. We further assessed linkages through our qualitative work between these PRISM determinants and local healthcare and public health system, as well as the potential impact of COVID-19 pandemic on these inner and outer contexts, because this intervention was launched early in the COVID-19 pandemic, and we wanted to be able to characterize its impact. We developed this process to prospectively examine the role that these determinants had on implementation outcomes when conducting the RCT, such as the appropriateness or viability of local implementation neighborhoods, and on subsequent observed clinical outcomes among people who inject drugs following the evaluation of the RCT. For example, the adoption and maintenance of ART or PrEP and MOUD treatment at week 26 post-baseline. This particular analysis that we're going to dive into now, I identified on path A in this figure, though, specifically draws on multiple data sources to account for how the contextual factors in the community environment affect the viability of delivering INTEGRA in local neighborhoods. Okay, so as previously mentioned, our evaluation utilized a prospective embedded mixed methods evaluation, and we specifically leveraged 6 different data sources. Our first data source was an HIV and MOUD service landscape analysis that was conducted during the pre-implementation phase. Then we did weekly brief ecological assessments through Qualtrics to obtain data on the local implementation neighborhoods. We collected and summarized data from our standing 094 protocol meetings. We collected participant data to better understand who we were reaching in which neighborhoods. And we also to characterize any protocol adaptations if they were to occur. And finally, during the early implementation phase, we conducted in-depth qualitative interviews, 39 approximately per site, that consisted of both participants in either study arm as well as mobile unit staff, as well as public health officials and HIV and MOUD providers in the local communities. And so what we did then is that these data were processed, coded as needed, and integrated in our monthly implementation science calls. And we did this to first document and implementation facilitators and barriers. We also used these data to make data-driven decisions about how to reach the target population, and also to inform, document, and classify any adaptations to support fidelity to our primary outcomes. And we used the STRM and FRAME-IS protocol for when that was needed. This current analysis leverages the first 2 data sources that are highlighted only, which I'll speak to a little bit more in depth. They say that a picture is worth 1,000 words. So I'm going to show you how we used our IS data to inform where to implement INTEGRA. Through our pre-implementation landscape analysis, We documented the geographic boundaries of local neighborhoods with high HIV and overdose rates at baseline. And you'll see those neighborhood boundaries documented in gray on the Google map there. Then we characterize proximity to MOUD, HIV, and primary care services in these neighborhoods by putting in a green geotag within the neighborhood boundaries. And then characterize proximity to institutions that may discharge people who inject drugs back into the community. And that could reflect hospitals, urgent cares, jails, or prisons that were within the neighborhood boundaries. And those are flagged with red geotags. Then, through the implementation phase, our weekly ecological assessment data was collected at each site through a Qualtrics survey. And we use that to document the date and crossroads of where INTEGRA was actually delivered. And we did that by placing a van geotag marker at those cross streets. So there's one van geotag marker for each unique cross street, and there's only one marker even if they were there for multiple days. We did this to compute the driving distance from the van's parking site to the implementation site, and the van's parking site is flagged by that P within the blue circle. And we also did this to triangulate locations where people who inject drugs were enrolled in what we were calling high enrollment neighborhoods, or neighborhoods where more than 30% of the participants in a given site were enrolled. We also characterized through open-ended prompts neighborhood factors that affected their ability to reach people who inject drugs in specific neighborhoods, and factors that affected their ability to provide integrated care in the mobile unit. New implementation neighborhoods were added to the implementation maps as needed, and you'll see those indicated through the blue geographic neighborhood boundaries. Qualitative responses were grouped by implementation neighborhood and then thematically coded quarterly and discussed on our implementation science team calls. The coding aimed to describe observed social, physical, drug use, and socio-political environmental contexts that affected a neighborhood's viability for implementation. So let's first review the characteristics of neighborhoods initially selected for implementation. The HIV and overdose epidemiological data identified approximately 3 to 4 priority neighborhoods in most cities and 10 neighborhoods in Houston. Overdose deaths were highest across all of the Philadelphia neighborhoods, while both Houston and LA had a broader range of overdose deaths that were identified in their priority neighborhoods. And similarly, the highest HIV incidence was observed in the downtown LA neighborhood, where LA and Houston still maintained a broader range of HIV incidence across their priority neighborhoods compared to the other cities. Houston had substantially lower access to services within priority neighborhoods, and you'll see what that looks like in a moment. Comparatively, priority neighborhoods in New York, Philadelphia, and some areas of LA had greater access to services, with the highest number of services documented in the Philadelphia's Kensington neighborhood. Probative observations identified that the higher number of services in Philly neighborhoods was due to a standing order for all pharmacies to provide naloxone. And naloxone is a medication that can effectively reverse an opioid overdose if given in time. And that standing order substantially increased access to those life-saving services across the city. The number of people who inject drugs who may re-enter the community within those neighborhoods was greatest in New York's East Harlem neighborhood, but relatively lower across the rest of the sites and neighborhoods. Okay. So the geographic distance across priority neighborhoods and the density of MOUD, HIV, and primary care services are going to be depicted on the pre-implementation maps on the left side of the screen. And what you'll see here is that 3 of the 4 New York neighborhoods were within relatively close geographic proximity to each other, and they had a relatively robust access to those services within their geographic boundaries. So you see that high concentration of green markers within their boundaries, sometimes obscuring the boundary of the neighborhood altogether, right? The same is held true for Philadelphia. by and large, where in DC, you start to see that it's characterized by access to fewer services in its priority neighborhoods, and comparatively across Houston's 10 neighborhoods, which covered much greater geographic distance, the service access was actually quite sparse. When we look at LA's neighborhoods, we see that there's more geographic distance between their priority neighborhoods, though there are some pockets within neighborhoods where there is greater access to services. So when we move into what the implementation neighborhood characteristics look like, I want to draw your attention to the first two columns, which reflect the priority neighborhoods that were identified in the pre-implementation phase in the very left-hand column next to the city's name. And then right next to it is the total number of neighborhoods where the intervention was implemented. And what we observed was that of the 24 priority neighborhoods identified in the pre-implementation landscape, 18 were initiated in the implementation phase, as were 17 new neighborhoods not previously identified in the landscape analysis through our use of EPI data. 6 priority neighborhoods were never initiated, including 3 in New York and Philly that were due to existing high enrollment neighborhoods. So there was no reason to initiate an additional neighborhood. And then also some in Houston, which had limited mobile unit parking options, or because other viable neighborhoods emerged using local response systems. And we'll talk about what some of those local response systems look like in a minute that help to identify new neighborhoods. The driving distance one way from where the mobile unit is parked to the implementation sites within a specific neighborhood on average reflects the greater geographic distance across the neighborhoods in both Houston and LA, meaning they spent much more time out on the road than other cities. And of the 358 participants that were enrolled as of by the end of April 2023, which was not the full sample that was enrolled, but it was the end of our analysis period for the first 2 years of implementation. We see that much smaller proportion of participants were actually enrolled in the DC site, and we'll get into some reasons for that here in a moment. All sites, with the exception of Houston, did have at least one high enrollment neighborhood where at least 30% of participants from that site were enrolled, but you even see across sites variability in the proportion of folks that are enrolled in a single neighborhood. Okay. So next I'm going to bring up the implementation maps. And as previously mentioned, the neighborhood boundaries were added to Google Maps in blue, and a purple van marker was placed for each cross street where the mobile van delivered INTEGRA services at each site. A magenta van marker now indicates cross streets within a high enrollment neighborhood. So looking at a map, you can kind of see where the high enrollment neighborhood is in proximity to other implementation sites. Oh, sorry. The implementation sites were relatively densely concentrated within New York, where 58% of the participants who they enrolled were enrolled in the East Harlem neighborhood. Similarly, the implementation sites were even more dense in Philly, where 89% of the participants were enrolled in the Kensington neighborhood. And from what you're looking at on your screen, it might look like there's only 2 geotag markers in the Kensington neighborhood that are magenta, but I promise you there's more. They're just so close to each other that at this scale, they look like there's only 2. And I forgot to mention that all of these maps are set to the same scale so that you're seeing the same geographic distance on each map. Okay. Here, when we get to DC, the implementation sites you see start being a bit more dispersed across their 6 neighborhoods that they ended up implementing INTEGRA in, with the exception of Ward 5, which is where you see a little bit more concentration in where the mobile van was, and where they enrolled 38% of the participants they enrolled. The implementation sites, you can see, were most dispersed within Houston's 16 implementation neighborhoods. And as previously mentioned, it was the only site without a high enrollment neighborhood. And that's, you can see just the vast amount of geographic distance they covered to implement the intervention there. Whereas in LA, sites were much more concentrated than in Houston, with the exception of downtown LA, where they were spread out a bit more. However, downtown LA was where 31% of the participants that were enrolled were concentrated. And so we'll talk a little bit more about why we saw that here in a minute. Specifically, next I want to go into some of the contextual barriers and facilitators that characterize the viability of different implementation neighborhoods and the benefits of utilizing additional systems to guide real-time implementation decisions beyond the pre-implementation surveillance data that we had started with. So across New York City, our implementation sites were more densely concentrated, and in East Harlem in particular, where we enrolled 58% of participants from the New York site, they were concentrated around a park which was known to have an open drug market. And in fact, East Harlem was its only recruitment neighborhood for the first year of the study until a police command station was established at the main intersection, which effectively dispersed the open drug market. However, the density of the implementation sites in all of the New York neighborhoods are often within blocks of each other in order to bridge different drug turf barriers that could prevent people who inject drugs from crossing specific intersections or streets to get to the mobile unit. And we see that reflected in a comment that was made in one of our steering committee meetings where a team lead said that we've identified places to move to keep things fresh. A gated area called Little Jungle, an encampment where folks sleep at night and use just 2 blocks from the mobile unit where it's parked currently. Some folks just don't make it that far. So bringing the truck over to the street will help us to be able to implement the intervention with them. And we see that, they were able to identify similar kind of encampments and open drug markets, which helped to facilitate more concentrated enrollment within their different implementation neighborhoods. So across Philly, the implementation sites are highly concentrated. And similarly, the Kensington neighborhood, where they predominantly implemented the intervention and enrolled 89% of the participants from that site, meant that they were actually in Kensington for 398 out of the 410 days they implemented. So they spent 2 weeks in West Philly. And when they were in West Philly, this is what they observed. They said, we started to go more to West Philly. Most folks are not injectors or not injecting opioids. West Philly, the people who inject drugs there, are going into Kensington anyway from home to buy drugs and to use drugs or to use services. So Kensington is still our most high enrollment neighborhood. And in fact, when they talked with folks in West Philly, they said they would prefer to access the van services when they were in Kensington versus in their home in West Philly. And in fact, the density and implementation sites along Kensington Avenue, where they parked the mobile units, spanned less than a mile, where they were parking in front of different metro stops, as well as Prevention Point, which is a well-known harm reduction service agency in the area. When we go to DC, the implementation sites were definitely less densely concentrated, and they needed to move the van around more to try and reach people. But their lower enrollment numbers really reflected a challenge in reaching people who inject drugs in the usual neighborhoods that they had typically been able to recruit folks for previous studies with good success. What they observed in their ecological observations was that they were in the midst of a rapid gentrification process that was coupled with overt police surveillance. And the descriptions of that are really rather intense, actually. They also observed shifts away from injection due to the increased potency of fentanyl in the drug supply, where younger people were reporting that they were more likely to smoke fentanyl than inject it to reduce their risk of overdose. And so what we see is and across our ecological observations is kind of DC's transition away from more open drug markets, and that the neighborhoods where there still was more visible drug markets, the staff deemed to be sometimes too unsafe to park the mobile unit for prolonged periods of time. And that's because in order to get the mobile unit parked and set up to deliver services, it takes a fair amount of time, and it's not something you can quickly pack up and leave if something starts happening in the neighborhood. So DC actually had a second mobile unit. It was a small Sprinter van. And then when they started using that, they said having a second mobile unit that is smaller is very helpful for field safety and security. Smaller unit, not used to implement integrated care, is making it easier to get in and out of these spaces quickly to scope them out. And so when they were in these other places, they were still doing outreach and recruitment and letting folks know where they could locate the mobile unit. And the mobile unit where that ended up being in Ward 5. And that's why Ward 5 ended up being the high enrollment neighborhood for DC. And it wasn't because people lived in Ward 5 per se. It's because that was the place where they would park outside of a major Metro Transit hub at Heshinger Mall, where people felt safe taking the Metro in and connecting with the mobile unit from the different neighborhoods that they were doing outreach in. That were, really highly concentrated with police surveillance and other things. And so we even see that police surveillance emerge again in response to using overdose data to help identify new places to implement the intervention. Where using the overdose data had previously guided, kind of the selection of neighborhoods. But what they learned in that they were doing a lot of community work with the Department of Behavioral Health and community-based organizations. And the INTEGRA team was even now part of a rapid overdose response team. But it also became public knowledge that wherever those rapid response teams went, the police also put up remote devices to increase surveillance in the area. So what that ended up meaning is that it drove people away from those areas and away from where they were moving the services to, and drove people more underground and out of reach. So then when we look at LA, here you see the implementation sites were less densely concentrated than New York and Philly. And the LA neighborhoods were not characterized as having open drug markets per se, though their drug use was definitely more reported as being more visible in downtown LA and some areas of Long Beach. What they really found when they got the mobile unit down there was that they had to get out and talk to people because the types of drugs that were being used and the route of administration, or ROA, really kind of varied from block to block. So they could park the mobile unit somewhere and they might discover that where they're at, most people are using alcohol or smoking methamphetamine. But they go 2 blocks over and 2 blocks up, that's where they might find people who were injecting opioids. And initially, there were a high concentration of homeless encampments and services at MacArthur Park. And we talk about kind of the limited utility of the epi data in the LA context, where the site leader said, overdose data and HIV maps took us to Long Beach, but the data are really not granular. So it was hard to locate where to actually park. So then our strategy was to ask the gatekeepers in those locations. In the beginning, it was a struggle because the gatekeepers didn't know where our population was. When we first moved to downtown LA, we followed overdose data to MacArthur Park. It was not useful. There were overdose deaths, yes, but they were not our people, meaning that the folks were not dying, who were experiencing overdose or passing were not injecting drugs. But what ended up happening while they were in MacArthur Park in downtown LA is they ended up getting connected with something called Project Roomkey, which emerged as a housing response during COVID. Project Roomkey provided a higher concentration of access to people who inject drugs because they were being housed in downtown hotels during the COVID lockdown. And so the folks who ran Project Roomkey and worked at the hotels were really keen and eager to partner with the mobile unit who could show up and provide services to the folks who were staying there. So that's how they ended up having downtown LA being a higher enrollment neighborhood. And you see that those mobile van markers are spread out a little bit more. That's because they were going around to different hotels like the LA Grand. And in particular, the density of the implementation sites within all of the recruitment neighborhoods in LA were uniquely tied to finding different housing types. So finding where the sober living and transitional housings were situated there in Long Beach, the hotels in downtown LA, and then related to Project Roomkey, you see where the implementation start popping up in the valley north of downtown, and then to the new neighborhoods to the east of downtown. And those were tied to the new tiny home villages that were being opened up to provide housing in response to LA housing crisis. And then specifically, the implementation sites in Long Beach accounted for the higher average driving distance in LA versus Houston. And here you see some reflection on that by the study team, where they say, in LA geography, everything is out of the way. Nothing is close. Makes it challenging to get places because the traffic in between distances. So it's not even so much the geographic distance as the time it takes to navigate that distance in traffic. That was a challenge. In contrast, we see that the Houston implementation sites were fairly spread out. And while neighborhoods might be known for having high levels of drug use similar to LA was less visible in terms of the drug use type and the route of administration that kind of really varied from neighborhood to neighborhood. So they actually ended up identifying, even though they had 16 implementation neighborhoods, a good number of them ended up being low yield neighborhoods that they only identified after they started getting out and talking to people. And here's an example of what that looked like. Here's a report from an ecological observation where they talked with a community member that stated that most of the drug use in the area is non-injection crack and recommended mobile unit moves further east. Stated main problem in the Sunnyside area is poverty. So social services, housing, jobs, ID, crime and prevention are needed more than help for opioid use. Even though the epidemiological data would have said that the Sunnyside neighborhood would have been one of the top areas to prioritize for implementation of this intervention. Like DC, Houston's implementation neighborhoods with greater enrollment were definitely linked to proximity to transit hubs, such as the Metro Light Rail, as well as trusted venues with high foot traffic in the local neighborhoods, such as specific gas stations. Often those gas stations were places people frequented to be able to procure drugs in the neighborhood, but they were also trusted by local community members as well. Something that was unique to Houston was the Houston's Fire Department overdose response reports, which helped them to identify new neighborhoods that were not identified by the EPI data in pre-implementation. And here you see what a snapshot of what that looked like, where the Houston Fire Department has an outreach worker that follows up with the individual that received care for overdose. Our peer navigation supervisor rides along with the outreach worker and shares neighborhood information with the 094 team when there are clusters of overdoses. And what this allowed them to do was to start identifying and scoping out other potential implementation neighborhoods while they were still within a neighborhood. So for example, here in Northside Village, that ride along helped them to figure out where to move the mobile unit to reach more people in Northside Village, and other ride alongs helped them to figure out what new neighborhoods to add as implementation sites that they hadn't been to yet. So in terms of discussion, our findings highlight the important connections between other community environmental contexts and the implementation of complex interventions in local neighborhoods. Specifically, neighborhood level drug use and geographic diversity alongside shifting socio-political factors, namely policing, surveillance, gentrification, especially in DC, differentially affected the utility of epidemiological data in identifying viable neighborhoods across sites. In sites where people who inject drugs were more geographically dispersed, proximity to structural factors such as public transportation, and spaces where people who inject reside played a role in determining suitable implementation sites. And the utility of leveraging additional data from local overdose and housing response systems to identify viable implementation neighborhoods was mixed. It worked very well in LA and Houston, But when that overdose surveillance data was tied to police response in DC, it had the opposite effect. Our study, of course, is not without limitations. Chief among them is that the assessment period in the neighborhood assessment period of neighborhood viability was not standardized, and the intervention was not systematically implemented in all priority neighborhoods. Of course, causality cannot be inferred in our results, and the mobile unit may have affected minor socio-political shifts in the implementation neighborhoods that we were not able to capture in any of our data sources. However, the triangulation of observations across sites and multiple data sources greatly strengthens the external validity of our findings. And finally, our findings contribute to the literature and suggest that data-driven approaches may provide a pragmatic strategy to guide the real-time implementation of integrated care models in local communities with heterogeneous geographic and drug use landscapes to better meet the needs of out-of-treatment people who inject drugs. And specifically, we demonstrate that integrated care delivered in mobile units can expand service reach to underserved communities. Few studies have described how or if a process was used to optimize reach and adoption of mobilized services. And we build on that by attending to the external environmental contexts that expand beyond traditional surveillance data as a pragmatic strategy to guide real-time implementation of complex interventions in underserved communities. This provides a framework for expanding a pragmatic, data-driven approach to expand the implementation of integrated care models for people who inject drugs across diverse drug use, socio-political, and geographic landscapes in the US. And with that, I want to acknowledge NIH's role in funding the HPTN and HPTN 094 protocol, as well as my colleagues' works who I cited in this presentation. And I think everyone will have access to the slide deck as well as the citations for reference. I'm also happy to share it with anyone. And finally, thank you all so much for this opportunity. I'm excited to discuss the study further.
Thank you so much, Laramie. Fantastic. Such a rich, we were commenting in the chat about what a great visual of hybrid one study design and such rich data sources. And then at that moment, I was wondering, how are you going to bring this all together? And you did. So this is all exciting. Let me open this up for questions to the audience. Do you have any specific questions for Laramie? Feel free to unmute, or if you prefer, just use the chat.
Yeah, absolutely. I can see the chat box now.
Perfect.
This is always the fun part, so please ask questions. Hi, Chris.
Hello, Laramie. So good to see you. And I'm sorry, there's someone vacuuming behind me. So in the next room, I hope it's not too loud. My question for you, on top of, well, not really a question, how proud I am of you and the work that you're doing. But my question for you is based on the work that you guys have done in HPTN 094, which was focused on people who are injection drug users, what do you think would be the next step that we might want to think about for integrated models for people who are using non-injection substances, including opiates, stimulants, etc., with regard to social support, integrated strategies, and even HIV-related support, whether they be treatment-seeking or non-treatment seeking?
Yes, thank you. And especially because there are, no kind of quote unquote gold standard pharmaceutical treatments for stimulant use. But I do think that based on what we've learned, and there is another paper that's in development. So I want to be careful what I say here because I don't want to say anything that might try to foreshadow what our outcomes are, because we don't know our clinical outcomes yet. So I just want to say that we don't know our clinical outcomes. We only have a specific sampling of observations through the IS data. But I do think given who we were able to reach and yet who were not eligible for this specific study, we could have much greater impact if we integrated care models that attended to both injection and sexual risk among people who use drugs that may or may not be specifically tied to opioid use, right? People were willing to engage and interested in the service. And I think the interest in PrEP in particular might be specifically more relevant for folks who are engaging in sex work or elevated sex risk that may not be injecting opioids, right? So I think you'd have a potential for broader reach and impact by integrating HIV prevention, harm reduction, and substance use support services, and what those substance use support services, whether they're buprenorphine or potential other evidence-based interventions such as contingency management, which has been found to work well for stimulant use disorder, could be more impactful. Also integrating sexual health and reproductive care for women. This became particularly salient during this study, given that the reversal of Roe v. Wade by the Supreme Court happened, and Houston was one of our sites. And what does that mean in terms of reproductive justice and health care for women who use drugs and men who use drugs for that matter, and the impact that has on their families and well-being, or people with reproductive potential. I'm working on my language. So I think that there's ways to grow when you're doing all that work to put these integrated services in communities, to grow the potential reach for folks who are in that community. And people definitely were receptive to something from the mobile teams. The mobile teams built good, strong relationships with the community. So being able to do more, that's not so much tied strictly to the current study design, right? I think could expand impact. Another thing that was definitely, missing, and it's because you can only do so much with one study, but something that could also be integrated across the board, be it the study or one with an expanded population, is access to mental health services. And the need for that, kind of goes hand in hand oftentimes with folks who are, dually impacted by unmet substance use and mental health needs. That was a long answer, but I have a lot of thoughts on this. So.
Yeah, no, it was, but thank you. Yeah, I look forward to talking with both you and Dr. Shopka more about this, some of this work. So thank you for what you've shared, and I'll let somebody else speak.
Thank you so much. Amy has a question in the chat. Do you have thoughts of why police presence affected implementation in DC, but not other locations?
Yeah, that is a great question, because in particular, you kind of see a juxtaposition between kind of some of the ecological observations in Kensington and in DC. I think it's the enforcement role, right? So you would see Kensington reporting on, oh, there's an uptake in violence, or there's more police presence. People are just kind of laying low, but it's not really affecting people's willingness to engage. The police presence in DC around these areas that were being gentrified, where there was new constructions or they were rehabbing new buildings, was intense. The descriptions of it was intense. They were putting up surveillance on poles. Like it wasn't just a cop car that was sitting there or a cop car that rolled through, right? They were fairly aggressive about it because they were intentionally trying to gentrify the neighborhood. So I think it was the degree with which there was enforcement or the sustained presence. And you saw the same thing happen. It's not like police weren't in East Harlem the whole time they were enrolling in East Harlem, but it's when they put in a physical command station. They literally took over a four-way intersection, built up platforms, and put the police there visibly. They did their command roll call on the corners of the street. It was that sustained visible presence that ultimately ended up, kind of deterring people and shifting the flow of where folks went from to access drugs. That was a great question. And
I appreciate that context for it too. So thank you so much. Were they like following you? Did it just so happen that the sites that they were targeting were the same sites you were targeting? Like, was it the same data points that they were using, or did they see where you were going and be like, oh, we need to go there too?
Yeah, I could be wrong, and this is why, that's one of the potential limitations. We don't know what effect the mobile unit had. But in most cases, the mobile unit wasn't the only kind of like service organization that was out there in the neighborhoods. The police already knew, and had presence in the neighborhoods by and large. So I don't think that it was the mobile unit that was necessarily drawing attention. Although if there was a stronger enforcement, people may be less inclined and willing to talk and engage in the services, right?
Got it. Thank you.
Yeah, great question. Thank you.